Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and today's topic is about inherited cancer genetic risks. And joining us today to talk about this is Alicia Schollmeyer with Willis Knighton Genetics Clinic. And thanks for joining us, Alicia.
Yeah, thank you so much for having me.
Absolutely. Okay, so you are a nurse practitioner and you specialize in genetics at Willis Knighton.
Yes, so I've been doing genetic testing, genetic risk evaluations for about 13 years now.
Cool.
And I'm very honored to be a part of the Willis Knighton Genetics Clinic. This clinic is something special, and it encompasses all kinds of inherited risks, including some cardiac risk or connective tissue disorder issues. But today specifically, we're going to be talking about those cancer risks and what we need to do about those.
Absolutely. Okay, and so being a nurse practitioner, you start out as a nurse, right? And so what made you decide that you wanted to get into genetics?
Oh, that's a great question.
Yeah.
So interestingly, I am the daughter of a 3-time breast cancer survivor.
Oh, wow.
And she just, watching her story over time develop and seeing how genetics could play a role in her care, it really drove me to want to do this, to help other people find cancer earlier so that they can prevent even their cancer from happening. So.
Absolutely. Wow,
Yeah.
that's awesome. Very special, and you have a personal tie, and so it just probably means a lot. Your work means a lot to you.
It does.
Sure. Yeah.
It does. And making that a priority in people's lives to know their genetic makeup, it truly can save their life. It truly can make them alive for future generations that would not have happened had they not known that information. So I'm excited to be a part of that.
Yeah, okay. And so cancer is something that can affect every individual, especially if you live long enough, just normal wear and tear on the body, right? Chronic condition, but it's also a hereditary thing that can be inherited based on your genes. So is there a difference between that inherited cancer versus the cancer that you could get maybe in your 80s or 70s?
Yes, for sure. So cancer in its simplest form is DNA change within the specific cell of the body. So breast cells, for example, or colon cells. In that, those DNA changes happen because of toxins within the environment, like you mentioned, personal lifestyle choices, things like that. So that DNA damage accumulates over time and eventually will develop into a mass. Well, patients who have a genetic predisposition, they have a gene, or all people have genes that are supposed to find cancer within their body. And so in a person who has an inherited risk for cancer, their DNA makeup is altered slightly so that DNA cannot make the protein it's supposed to find cancer within a specific area of the body and kill it. So that is what puts them at risk. They already have DNA damage that proactively works to make them at an earlier diagnosis of age, things like that. They get cancer faster. They get cancer in rarer types of places.
Yeah, and maybe in young patients, you probably see that as well. Specifically, I think of breast cancer, and have talked with many patients just through, my time here at KTBS, who have had breast cancer, in their 20s, but they also had the BRCA gene.
They did.
If you wanted to maybe talk a little bit about that, and then maybe other genes that are associated with the hereditary cancer.
Sure, yeah. So BRCA mutations, again, is a tumor suppressor gene. Its job is to find cancer within the breast, but its protein works within the ovaries. And so if it's not functioning well, you can have a lifetime risk for breast cancer up to 87%. A person is much more likely to get cancer. It doesn't mean they're going to get cancer.
Yeah.
It just means that they're much greater risk. And the same thing happens for the ovaries. There's a 63% chance of ovarian cancer in BRCA carriers. And males who have prostate cancer, many of them have a BRCA mutation. And we're knowing now that a BRCA2 mutation it actually increases the risk for prostate cancer by 60%. That's crazy compared to the 15% risk in the general population. Yeah. So if you know that information, obviously that's going to change what you do. It's going to change where you're looking and how frequently you're looking.
Right.
And the same thing happens for a disorder called Lynch syndrome. Lynch syndrome increases the risk for colon cancer, again, up to like 86% lifetime risk. And uterine cancer, it's about 63% to 80% risk. And there's multiple kinds of cancer associated with Lynch as well. So it's important for us to know so we can look for at the stomach or the small bowel or the pancreas, for example.
Yeah, okay, and Lynch syndrome would affect all of those organs?
Yes,
okay.
And plus some.
Oh gosh, yeah.
For sure.
Wow, yeah, so that's pretty, scary when you think about it, but knowledge is power, and so if you know that you have the gene, you can be a little bit more proactive about it.
Yes.
So tell me about a little bit about the process of someone coming to you and saying, I want to do genetic testing. Like, when should someone maybe consider something like that?
Okay, so if they have a family history that is a little striking, like what we talked about, early onset cancer in a family, multiple people in the family having the same types of issues, they should definitely reach out to their doctor and see if genetic testing is a good idea. But what we do in our clinic is we sit down with patients and we analyze that data. We actually will plug in risks of that specific person, say whenever they started their first menstrual cycle, or if they're a smoker or whatever, and we can put that into risk calculations and we can spit out a number and we'll say, okay, this is your specific risk for cancer with or without a gene mutation. And so then we'll go into the genetic testing, do the testing, analyze the report with the patient once we get those results back, and then help them determine what they're going to do about it.
Yeah, awesome. Very cool. So if you're just joining us, we're talking about hereditary cancer and genetic risk factors. If you have a question or comment that you wanted to bring on to Healthline, give us a call at 318-219-4569. We're talking with nurse practitioner in genetics, Alicia Schollmeyer. So we'd love to hear from you and any questions that you have specific to this. So when we're talking about, genetic risk factors, this is something that is inherited that you just can't really do anything about, right? So we're not really talking about lifestyle risk factors.
Right.
So what are some of maybe those misconceptions that you have with patients that you commonly see about genetics or just about maybe cancer in general?
Right. So people who have a genetic link to cancer, they think, oh my gosh, I am so going to have cancer. It's just the shoe is going to drop at some point and it's going to happen. I have a very high risk for cancer. And in some cases there is a risk, but it doesn't mean that it's 100% risk. It doesn't mean that you are going to get cancer. It just increases the likelihood that you could. And if that's determined, then why not do something about it? Let's not just wait and look and have things happen to your family that doesn't have to.
Okay. And so, knowing that, I just think of breast cancer because it's something that you probably see. One thing that you want to look at is maybe like family history. So, if your grandma, mom, aunt, and maybe if there's even like males in your family that have breast cancer, that's probably a red flag.
Oh yeah, for sure. And we do a 3-generation pedigree whenever we see our patients. So we're looking at great-grandparents, first cousins, great aunts and uncles sometimes can be included in that too. But we're looking at the whole picture, the whole family.
Okay. And when someone is doing the genetic testing, so take me through the process. Is that like a blood test or other testing that you're looking at?
Yeah, so we do blood tests, but there's also some other less invasive testing like saliva tests or buccal swabs. You just swab at your cheek and stick that in a tube and send it off. And that
like
takes
ancestry.
Yeah, exactly like ancestry.
Yeah.
So it takes about 2 to 3 weeks to get the results back, and typically insurance would cover that, and so we work really closely with the insurance companies to make sure that the cost is going to be something that is feasible. We want to make sure that this is accessible to all people of all ethnic groups and all socioeconomic status. So
yeah. Okay.
It's important.
Right. So what role does the testing play in identifying the risk? So you mentioned like the calculator that you put, or you're calculating those risk factors. So, let's say someone has the BRCA gene, what was that percentage for cancer? And then I guess, do you also look at lifestyle in addition to the genetic risk factors that they already have, and then that's how you come up with this big number that's specific to each person?
Absolutely. So specifically risk calculations with lifestyle included are really associated with Lynch syndrome often, because what happens is if you're exercising more, if you're eating green leafy vegetables, if you're taking care of yourself, drinking water, not having a lot of alcohol intake, all those things will actually increase the risk for colon cancer and things. And so there's some changes you can make just by yourself without anything involved. But if there is a risk for breast cancer, for example, in a BRCA carrier, there's options for them too. They can take a pill that may actually even prevent their cancer from happening. So if they have an 86% lifetime risk for breast cancer, there's a pill they can take before they get breast cancer that'll drop it possibly even by half.
Wow.
That's huge. And then, if they have an ovarian cancer risk, by taking out their ovaries, obviously they're reducing the risk for ovarian cancer, but by default you're also reducing your estrogen and your progesterone that's created by those ovaries, and that is something that kind of drives breast cancer development. So if you take out your ovaries, you can reduce the risk for breast cancer even further.
So the pill, can you talk a little bit about that?
Yeah, so there's some different options, but tamoxifen is a pill that often we treat hormone positive breast cancer. So there's, like I mentioned, estrogen, progesterone kind of driving that cancer to develop. Well, we now know that we can give that same pill to reduce the risk for breast cancer in BRCA carriers, because often it is a ER/PR positive type cancer situation. So if we know that, the pill can reduce that risk for sure.
Okay, yeah, very interesting. I did not know that. And so what about for someone, maybe there isn't obvious signs of cancer in their family, and maybe they don't have these genes, but you don't know until I guess you test.
Right.
Would they be a candidate for genetic testing, or would you recommend that for someone who doesn't really have extensive history of cancer in their family?
Well, we know that there are family members or families that don't have a lot of cancer. For example, there could be a BRCA carrier who all they have in their family are uncles and brothers, and there's a single woman. Well, that woman could have BRCA mutation, but she wouldn't have seen that because there's no women in the family. So there's the risk for breast cancer obviously in her is really high. So if there is concern about it, and we look at the personal risk factors and do those risk calculations and see, hey, you have like a 20% chance that this is actually hereditary, testing could be offered in those situations. Specifically, there is an ethnic group called Ashkenazi Jews who have a 1 in 40 chance of having a gene mutation, as opposed to a 1 out of 400 chance. So 1 in 40 is way high. So we want to be able to especially offer testing to those people if there's any Jewish ancestry, for sure.
And then let's say, I know I'm giving you a lot of like case studies or hypotheticals, but let's say if someone, doesn't know their family history, doesn't, maybe they were adopted or they don't know any of their genetic history at all, would that be another reason that someone would consider genetic testing, or have you seen that? Yes,
we have. So it's called limited family structure. So if you don't have any family members that you know of, like as in an adopted case, that could be something they could consider for sure. Yeah.
Okay, very cool. So if someone like that wanted to just pursue genetic testing, tell me about, is this covered by insurance, or is this something that you need a referral from your doctor to pursue?
Well, often we do recommend that you talk to your primary care doctor about it and determine if that's an option. But yes, most people can get genetic testing covered. It depends on the insurance type, whether or not they're going to pay for it, but there's always an out-of-pocket possibility. Like you could go and just order the testing and pay cash out of pocket for it. So there's often sliding scales that can be done based on your income. So if you are of a lower socioeconomic status, you may pay less cash price pay than someone who maybe have more, but it's still accessible. It's a possibility.
Very
for
cool.
Sure. Most genetic companies will have an out-of-pocket cost of like less than $250.
Yeah.
So I think that's very reasonable.
Yeah, because some can be a little crazy and maybe out of the price range, but
that's why we choose the right test. That's why you
Yeah.
go to a genetics person, so that you can make sure that the test that is ordered is something that is within budget and is through a company that we know will work well with patients.
Yeah. Okay, so Lynch syndrome, I think this is a very interesting topic. So we've talked about the BRCA. I feel like a lot of people have heard that, or at least maybe somewhat familiar. But Lynch syndrome, what are you looking at on the results, the lab results? Like what shows you that someone has Lynch syndrome?
So there's several genes that actually cause Lynch syndrome. So that's PMS2, MSH6, MSH2, EpCAM, MLH1.
Oh, wow.
Okay, so those clusters of genes increase the risk for colon polyp development. And someone can go from no polyp to cancer within a year time frame, as opposed to the general population that goes from no polyp to cancer in a 10-year time frame. That's why we do colonoscopies at the frequency we do, because we know that those polyps take a long time to develop into cancer. But if you have Lynch syndrome and that risk goes so rapid like that, doing frequent colonoscopies, one every year, can remove those polyps before they turn into cancer. And there was a study that came out several years ago that showed that people who had their colonoscopies with Lynch syndrome, if they had them every year, nobody died from colon cancer. That's huge. Nobody died. And that's obviously my goal, and something that I'm super passionate about is I don't want to wait until cancer happens in these cases, because we know the cancer risks are super high. And there's things like, there's a study for Lynch syndrome carriers too, who they took aspirin, simple as aspirin, every day for 5 years, and it reduced their polyp risk. It reduced the amount of polyps that were formed over time. So that's great, something you can do. And then uterine cancer risks, there's the option to do a hysterectomy as soon as you're done having children. If you know you have a high risk for uterine cancer, why not take out your uterus? You're not using it anymore, so to speak, right?
Absolutely.
So you were also talking about some of the other risks for Lynch syndrome. So there's brain tumors associated with it. So perhaps we have a really low threshold of suspicion for that. Maybe we do an MRI of your brain with even subtle changes in your personality or whatever that may indicate you have a brain tumor. Headaches more frequently, lethargic more often, things like that. We would pursue imaging a lot faster in Lynch syndrome carriers because we know that risk exists. And in pancreatic cancer, there's really not a screening for the general population for that. And so that is a screening option for Lynch syndrome carriers, to have a endoscope where they go down with it's like an ultrasound one. They go down and they look at the pancreas from inside the person, because it's not really well seen on imaging. And so that's a cancer that's easily missed, and often there's no symptoms to it until it's stage 4. Well, we don't want to get there. We
Yeah.
want to find it when it's really, really small so that that can be cured.
Absolutely. Yeah. So give us a little bit of like a genetics lesson, if you will. Just because someone has, like, let's say my mom has the BRCA gene or something, does that mean that I 100% am I going to have the BRCA gene?
No,
Yeah.
you have a 50% chance. And the reason why is you get one set of chromosomes from your mom and you get one set of chromosomes from your dad. And you have essentially 2 copies of every single gene that determines your eye color or your height or whatever. And that these genes, just increase the risk for cancer because it's not working the way it's supposed to. So if you inherit a gene problem from your mom, for example, you could have the DNA issue passed down to your children, but you have a good one too.
Yeah.
You have a chromosome from your other parent that was
Right.
fine. And so you could give the bad gene to your kids, or it could happen to be the good one, and it stops with you. So it doesn't skip generations, which is another one of those misconceptions we talked about. A lot of people think that the cancer skips generations, but it's a dominant gene in most of these that if you have it, there is a risk. But if you don't, you go back to the general population's risk for cancer. So that's good to know, because if I'm in a family with BRCA carriers and I didn't inherit that same gene, then I don't have to be concerned about that. So some people think that if they do genetic testing, it's going to cause all this anxiety. Well, sometimes the reverse is also true. Sometimes it relieves you from knowing that you did not inherit the risk for cancer, other family members did.
Yeah, and I mean, like we were saying earlier, it might be an upfront cost to do the genetic testing, but to save you if you did, let's say, go on to have cancer and then pursue chemotherapy and radiation, whatever comes along with the cancer journey, you might save yourself a lot of headache later on, because okay, I do have the gene or I don't have the gene, and if you do, you may have some steps that you can take, to maybe prevent your risk even more, like the pill you were talking about, or removing certain organs,
or even just high-risk screening. So in BRCA carriers, we were talking about Lynch syndrome, doing annual colonoscopies. Well, BRCA carriers, they need to do imaging every 6 months on the breast, and using different modalities. So mammograms, but also MRIs of the breast, so that we can watch it very closely, because some cancers hide behind that dense breast tissue.
Right.
And so if that can be found in a different modality, that's what we need to do. So you can do more frequent screenings, and you can also do surgeries and pills. And but if you have a BRCA mutation, you were talking about treatment options. That's something that, or even any of the genetic predisposition genes, there are some medications that target that specific gene mutation. So in BRCA carriers, there's a pill that it's called a PARP inhibitor, that its job is to break the cancer cell and the DNA. So there's DNA damage that happens on one of those chromosomes we were talking about within that cancer cell itself. So not you, just your cell. So if you have a DNA break already and you have this cancer cell that's working with this one, we can break the other one, and that tells the body, hey, we're going to take this cell out and we're going to prevent this from growing. So it prevents the cancer from growing, or even treats cancer.
So I'm going to deviate a little bit, sorry, off topic, but this is making sense to me, because I've worked with cystic fibrosis patients before, and that's heavily relied on different genetic mutations, and there's a drug that targets those specific mutations, and they're calling it the miracle drug.
And helping. Advances in technology like that, if we know there's a driver behind that cancer, you want to attack the driver, because the driver's what's making that cancer happen, or that disorder, that issue happen. So there's options,
Very interesting. Okay. So it's just a whole other world of, and maybe advancements, like you said, in technology. We're just constantly advancing every day. So let's talk about from like your patient perspective. When you're sitting down and talking with these patients, I'm sure it can be a little bit of a nerve-wracking experience because you don't know either way. Maybe you do tell them, oh, you have the BRCA gene, but tell me like how do you sit down with patients to help them understand and, decipher their own results?
So there are 3 potential results that we can get. One is a positive. We know the specific cancer risks associated with those. Some are really high, some are just kind of slightly higher than the general population. And so we talk about what their risk is compared to just the average person and outline their medical management based on that result. If it's negative, it doesn't mean you don't have a risk for cancer. It just means that risk is not as high as one would have with no genetic problem or with a genetic problem. So that person who has no genetic problem but has a significant family history, we go through that negative result and we say, okay, even though you're negative, you still have this 20% risk for breast cancer. There's options. Again, you could have an MRI of the breast. You potentially could meet criteria for the pill to reduce your risk, even if you're negative. So positive and negative still deserves a good conversation. And there's that third result, which is the variant of uncertain significance. And those changes in the DNA could just be what makes you a unique individual. We all have unique DNA that makes us who we are. And so it just means that lab hasn't seen that specific value enough to be able to make a decision. They have a very important job at the genetics lab to know that they know that this particular mutation causes a problem or doesn't. So if there is a high risk for breast cancer, they want to know that they're not telling someone to go and have serious surgeries like bilateral mastectomies to reduce their risk for breast cancer. So they call it a variant because they haven't fully classified that enough to say, oh yeah, it really is a problem, or it's not a problem. So they keep it on, and they keep on watching that and make sure that what they're telling patients is actually an accurate thing.
Yeah, right. Okay. And yeah, because I mean, it's really important to know for sure, one way or the other, those 3 different things that you were talking about. Okay. So we only have a couple of minutes left, but real quick, tell us, like if someone has a general population risk, what are some of those lifestyle risk factors that you can maybe reduce?
Yeah, so general population, if they're negative, truly negative, they can exercise, do weight loss. The more weight you have, the more estrogen your fat cells create. So definitely something to consider.
And alcohol as well-known smoking.
Right, of course, yeah.
Okay, yeah.
Skin protection if you're at risk for melanomas and things like that.
Well, good stuff. Thank you, Alicia, for coming in. So we just have about 90 seconds left, but where can we find you here in Shreveport?
Okay, so Willis Knighton Genetics Clinic, we're currently based out of the Cancer Center. So because a lot of our patients are cancer patients or family members of cancer patients. So they can call us at our clinic at 318-212-6258, or you can go on the Willis Knighton the Willis Knighton website, willisknighton.com, and search for genetics there, and you'll find our pretty faces up there. And that's how you can get in touch with us. Yeah.
Love it. And so are you accepting clients right now or patients? Yeah.
Yes, new patients who don't have any family in the Cancer Center. We're even seeing patients who are at risk for neurodevelopmental disorders or seizures. We didn't talk about any of that, but cardiac problems, Ehlers-Danlos syndrome. We handle all of those genetic issues.
Right, yeah. I mean, there's a whole other, anything you can think of.
Right.
There's probably a genetic tie.
Yes.
There. So, okay. Well, thanks for coming in. And if you missed this and you wanted to rewatch it or you didn't get to tune in, visit our website at ktbs.com/Healthline the number 3 or /podcast. Thanks for joining us.